What I want to do today is to talk a little bit about our fentanyl protocol. It's called SIFI, Symptom Inhibited Fentanyl Induction. And the reason I wanted to address this is because it seems to have caused some controversy. And I think some of this just comes around this concept of using fentanyl clinically in the age of the opioid epidemic. And I get it when I present this in a few slides without a lot of context. I can imagine it raises more questions than answers. Let me provide some background on how we started using fentanyl in the first place. I have the benefit of having practiced addiction medicine before the fentanyl era. When people were using heroin, opioid tolerances were much lower. So a patient would come into hospital with a little bit of morphine oral solution. We could meet their opioid requirements, get them out of withdrawal, and then rotate them on to methadone or buprenorphine, whatever was required. Very quickly, we saw opioid tolerances skyrocket as people started to use more and more fentanyl. And at a certain point, fentanyl was essentially the only illicit opioid that was readily available on the streets of Vancouver. We started escalating oral doses of morphine. We started using parenteral morphine, and then we ended up switching to hydromorphone, which is about 4 to 5 times more potent. And then even with high doses of parenteral hydromorphone, there was a segment of our population which we would not be able to adequately meet their opioid requirements and get them out of withdrawal. These patients would frequently leave hospital before their treatment was completed, so they would not meet their medical surgical needs and they would have bad outcomes. So then it struck me at a certain point, it's like, geez, maybe we need to use IV fentanyl for a certain segment of the population. So we came up with an objective way of titrating fentanyl intravenously in a patient who proved to be difficult to treat with hydromorphone or other opioids. The protocol that we created is pharmacokinetically derived and was based on time to max CNS levels of intravenous fentanyl. Now, fentanyl is very lipophilic. It goes into the CNS very quickly. So we're talking about 4 minutes from injection to the brain. So then we created a protocol where it's dosed every 5 minutes. So patient gets a dose of IV fentanyl. We wait 5 minutes. We do our sedation scale where we're using the Pacero sedation scale. In the past, we were using the RAS score. That's more of a critical care score. So when we're doing this on the ward, we use Pacero. So inject, wait 5 minutes, do our sedation score. If vitals are fine, they haven't met our sedation threshold, another dose. Keep titrating until they're comfortable and out of withdrawal, at which point we know how much fentanyl was required to get them out of withdrawal and comfortable. And then we would give 50 to 100% of that amount every 1 to 3 hours on a PRN basis, on an as-needed basis, to keep them out of withdrawal. So we started using this protocol, and it was hugely successful. It's now we have a pre-printed order set in our EMR, and we saw patients that had a history of frequently leaving hospital before the treatment was complete because of opioid withdrawal, remaining in hospital and having the treatment completed. We also saw some of these patients then rotating onto MOUD, whether it's buprenorphine or rotating onto methadone. So that's a huge success. There's some natural criticism and questions that come up with this. Let's talk about what this protocol is not, and let's address some of those concerns. We're not using IV fentanyl as an opioid agonist therapy option. The patients know that they're not going to receive this medication when they leave hospital, right? So putting patients into withdrawal almost as a punishment to get them off of fentanyl, it doesn't compute. We're only doing this as a temporizing measure for patients to meet their medical surgical needs and then to rotate them onto opioid agonist therapy. Some people will say, well, what if a patient's never had fentanyl? Now they're going to experience fentanyl. And yeah, that's legitimate. We would never use this in somebody who doesn't use fentanyl. I mean, this is not the rule, it's the exception. We're talking about refractory patients who have failed hydromorphone, who are still in withdrawal, and who are at risk of leaving hospital. This protocol, we titrate fentanyl, and we stop the titration once the patient's out of withdrawal and comfortable. So in that way, it's a symptom inhibited protocol. The induction is inhibited or stopped based on a patient's level of sedation and lack of withdrawal signs and symptoms. So in that regard, we decided to call it Symptom Inhibited Fentanyl Induction, SIFI for short. Okay, that's a brief overview on SIFI. If you have any questions, please feel free to reach out in the comments, and I'll do my best to address the questions that might come up.